this presentation, the first one of the new year. So Karen and I both welcome you and wish you a very happy start to the new year. We'd like to kick off this session by giving you a bit of introductions to who we are. Both Karen and I are part of the Veteran Access Research Consortium, or the VARC, which is actually housed across Ann Arbor, Bedford, Denver, and the Iowa City VAs. We are also part of the ARC network, which is comprised of researchers interested in access research, which is comprised of both VA and non-VA personnel. I am part of the VARC as a communication scientist, and I'm also on faculty as an assistant professor within the Division of General Internal Medicine at the University of Colorado School of Medicine.
Thanks, Demetria. And hi, everybody. I'm Karen Albright. I, as Demetria already alluded to, am also part of VARC. I'm a social scientist trained as a sociologist, and my focus across my career and in the work that I do with VARC focuses on social determinants of health. I'm also the associate director at the Denver-Seattle Center of Innovation, which is supported by HSR&D in the VA. And I'm an associate professor in the Division of General Internal Medicine at the University of Colorado School of Medicine. Demetria and I are really excited to present this work to you today because we feel that it is, growthful and promising and generative for the coming years. We will explain more what we're about ready to do, but we have done a lot of work with the Delphi panel and with veterans in order to understand how to move the field of access research forward. But before we begin to describe all that, we wanted to ask you, so that we can understand where you're coming from, what your roles are in the VA or if you're outside the VA. So I want to turn the polling over to Rob here for a second. Rob?
Thanks, Karen. Yeah, and that poll is up and running now. And the question is, I apologize if I'm repeating what Karen just said, what is your primary role in VA? Answer options are student, trainee, or fellow, clinician, researcher, administrator, manager, or policymaker, and then other within VA and other outside VA. And if you like, if other is your answer, you could tell us more detail about that by either sending it to the chat or the Q&A, and I can read that to our presenters afterwards. But answers are streaming in rapidly, and I think we'll just give people just a few more moments, Demetria and Karen, to make their choices before I close the poll. And things have slowed down, so I'm going to go ahead and close the poll now. Just give me a second here. I'm sorry, I'm having trouble with the interface. It keeps popping up something in front of the button to close poll. Okay, so the poll is now closed, and I will share out the results, and then I'll read them off to you. Only 8% answered student, trainee, or fellow. 5% answered clinician. The largest number, 42%, answered researcher. 13% answered administrator. 9% other within VA, and 18% other outside of VA. And some of those answers are veteran and advisory board member, coach and outpatient access for OVAC, systems redesign, health system specialist, within VA, associate chief nurse for research. What else? Researcher and research assistant. So I'll close the poll now, and we're back on your slides, Karen.
Great. Thanks so much, Rob. And thank you to everybody who answered the poll. It's really helpful for us to know who you are and who's interested in this work. And now many of you may already be familiar with this, but we wanted to make sure that everybody understands the context of what we're doing and why we're doing it. So VARC receives funding from HSR&D to advance access-related research within the VA starting about a year ago. And there are a lot of arms to what this consortium has been tasked with doing, and a lot of exciting work going on. So some work groups within our larger group have been tasked with assessing the current state of the VA access research, which we'll talk a little bit about in just a minute. Another group has been compiling and developing metrics that are used to measure access, and both of these groups have recently presented in CyberSeminars the progress of their work. And VARC has also been tasked with and working with soliciting access researchers' opinions about the directions for future VA research. And so today's CyberSeminar really focuses more on the last one there. We're focusing on the activities of the Stakeholder Engagement Workgroup. And our mission in this work group is to identify high-priority access-related research questions that we're going to recommend that HSR&D focus on as much as possible in the coming years. And at the Stakeholder Engagement Workgroup is led by those of us that are located at the Denver site. And you can see the names of the researchers involved on this slide. Mike Ho, myself, Demetria, Kelty Felling, Joe Simonetti, Evan Carey, and Erica Valdez. And so our group, supported by the rest of VARC, of course, too, has engaged access researchers both within and outside the VA. We've engaged VA operational partners, and we've engaged veterans to try to understand what their perspectives are about the most important access-related research domains that we think, or that they think, the VA should address in the next 5 to 10 years. And the ultimate goal here is to inform the funding priorities for access research, and thus ultimately help shape the direction of the field. And of course, we're going to talk more in detail about all of that shortly. But let's give a little context to what we mean here by access research. There are multiple definitions out there, but the Institute of Medicine, about almost 30 years ago now, identified access to care as having the timely use of personal health services to achieve the best health outcomes. Pretty broad definition, but one that certainly still works. And there are multiple components to access to care, of course. People often talk about access to care as incorporating coverage, because certainly insurance facilitates entry into the healthcare system. Services, because certainly having a usual source of care is associated with receiving recommended screenings and prevention services. Timeliness is another important component of access to care. Essentially the ability to provide health care when there is a need for that. And also workforce. It's important for access to have providers that are capable, qualified, and culturally competent. Now, there are, of course, most people on this call, I'm sure, know that there has been a lot of work that has been done in access research. And one of the models that our work has been based on or taken inspiration from is what's often referred to as the Fortney model. This model with John Fortney and colleagues has established, multiple dimensions of access. You can see here on this slide that these are some of the observable measures that Fortney and colleagues have identified. And so when we think about access, they've identified the geographical dimension, which might incorporate things like travel distance and time. The temporal dimension, the time it might take for somebody to make another appointment, the time it might take them to wait in the reception room before they can see a provider. There's a cultural observable dimension with issues around language match and provider or public stigma, digital observable measures around connectivity, and financial observable measures having to do with things like eligibility and out-of-pocket costs. But there's also, in addition to those observable measures, there's also a number of dimensions that Fortney and colleagues identified around the veteran experience and perceptions, which may be a little bit more difficult to measure directly, not always, but sometimes, but are extremely important as well in terms of the experience of access and what we know about how we can, what the pathways are in terms of what we can improve. So in this set of dimensions, they identified in the geographical dimension, ease of travel, in the temporal dimension, time convenience, and then with cultural dimensions, understandability, trust, self-stigma, digital connectivity opportunities and usability and privacy, and financial in terms of eligibility, complexity, and affordability. So all of these things are important components of access, and we're mentioning them here at the beginning of this so that you can understand the work that we did to try to build on this and try to understand this more, particularly with our discussions with veterans. Now, I mentioned already that one of the tasks and missions of VARC was to and is to understand what the current access research portfolio looks like within the VA. And I want to give a little bit of information about this here too before we begin to describe what we did with the Stakeholder Engagement Group. So the Portfolio Review Work Group, which is based out of Ann Arbor, looks back at the past 5 years of VA access research and found, so they conducted a web-based review, identified about 211 projects that had to do with access-related research within the VA. They went through a variety of steps to supplement that, including engage in a number of operational interviews. And the total there was 266 projects that they ultimately identified as relevant to access research. Then they analyzed what that work was, and almost half, let's say, of the access-related projects were ones that directly measured access. And more of those projects tended to directly measure actual patient access as opposed to patient perceptions of access. You can see the breakdowns on this slide right here. They also found that of those projects that had been funded by VA, relatively few were interventions. But those that were interventions tended to focus on geographical and digital barriers to access. There were relatively few projects that focused on cultural or financial barriers to access. So this is interesting stuff, but the upshot here for our work and for using this as a jumping off point is that over the last 5 years, what we know is that the VA has developed a robust portfolio around access-related research, and much of the intervention and evaluation work that has been done has focused on digital and geographical barriers. Now, a substantial portion of the interventions have a lot of promise, and they engage in pre-implementation work, but they fail to be translated or operationalized. So we hope that this gives you a little bit of a foundation to understand the universe in which we were approaching this, and used as a jumping off point to reach out to veterans, to operational partners, and to VA and non-VA access-related researchers to understand where we might recommend the VA move in the future. And with that, I'm going to turn it over to Demetria, who's going to describe the first part of that process.
Thank you, Karen. So one of the great things about what we've covered so far is Karen was able to kind of give you a bit of background as to what brought us here and why we focused on this project. So now we're going to go a bit into detail about the what's next. So we kind of know where the VA is in terms of access research and what that looks like and exactly what we've been able to find out. But we want to take it a step further. And so with that, we wanted to move forward and solicit perspectives about the most important access-related research domains to address next. And in order to do that, we conducted a stakeholder engagement work group that did a couple of things. One, conducted a modified Delphi panel. And secondly, there were a series of dialogues that Karen and I had with veteran engagement boards. As it relates to the Delphi process, there were multi-round engagement sessions involving 22 Access researchers and VA operational partners in which these experts were able to identify important access-related questions and then rank them in terms of priority for VA support. We also garnered veterans' perspective on those questions that the VA researchers created and also thought through and asked the veterans what is relevant as it related to access-related issues from their perspectives. Now, there were three veteran engagement boards that we were able to connect with. Iowa City, we were also able to connect with Ann Arbor, as well as Bedford and Boston. And the reason Bedford and Boston are together is because there's actually a partnership between the Bedford VA as well as the Boston VA research centers. Those veteran engagement boards, depending on the location, actually meet either monthly or on a quarterly basis. We also wanted to be able to provide you with a bit of background regarding the Delphi method for those of you who may not be familiar. In brief, the Delphi method was actually developed by Rand in the 1950s, and it was originally created to forecast the impact of technology on warfare. What's interesting about the Delphi process is that it aims to determine the extent to which people, oftentimes these experts, either agree or disagree about a given issue, and typically via multiple rounds ultimately arrive at a consensus opinion or an expert opinion. Delphi has been described as a qualitative and quantitative and mixed methods approach in terms of conducting research. What's really nice about that is that it involves anonymous collection of the opinion of these experts, plus the tightly structured nature of the process, which is carefully monitored, and the often quantitatively described results allow you to think through and situate one single methodological category of research. The modified Delphi approach that Karen and I moved forward with was conducted over the course of 4 stages. Within the first round, the panelists were actually invited to respond to the following question. What are the most important access-related questions for the VA to answer in the next 5 to 10 years? Now, there were 22 panelists that we solicited this question, or should I say we solicited responses from. And as you see in round 2, we then asked them to rank those 83 unique research questions that we actually received back. So we received quite an overwhelming response, which allowed us to be extremely productive in terms of being able to winnow down exactly what would be highest priority for the VA to consider. So from those 83 unique research questions, we asked the panelists to then determine and rank them based on highest priority on a scale of 1 to 3. Only the highest priority questions were retained. Now, when I say highest priority, these were questions that either ranked 1 or either close to or at 2. So in round 3, those panelists were represented with the questions that were winnowed down from the 83, which actually became 18. And from those 18 questions, they were asked to determine and to rank them based on the top 10. Moving on to the 4th round, from those top 10, the panelists, we actually met virtually due to COVID. Originally, we were scheduled to meet in person, but because of obviously the onset of COVID, there were changes made to travel and such. So the meeting was held virtually, and all the panelists convened, and we were able to move forward with a consensus of the highest top 5 priority questions that they should consider. Now, to give you a bit of background of who the participants were with the Delphi panel, as I mentioned previously, there were 22 panelists that participated. What we really thought allowed our conversation and the diversity of the questions that we arrived at to be so diverse is because of the panelists that we were able to convene together. They not only spanned across VA and non-VA researchers, but it also was inclusive of operational partners, and it spanned the entire country. So for example, you can see we had participants and we had folks from Stanford, as well as LA, as well as Salt Lake City, as well as Duke University, as well as South Carolina. So it was a very diverse group that we were able to bring together and solicit feedback from. Now, the top 10 research questions that the panelists were able to bring together are presented before you. And we're not going to take the time to read through all 10 of them, but I will read a few of them and ask you to reflect on all the remaining. So I'll take, for example, the first top research question. Are there specific groups of enrolled veterans who encounter barriers to care? An example would be language literacy, transportation, discrimination, etc. And could targeted interventions enable these groups to overcome these barriers? That's one of the questions. Another question, for example, how should veteran access to care be defined and measured in the VA and in the community? And specifically, they were thinking about what are the best variables to use, as well as the best data sources to use in order to come up with a definition, as well as the measurement for veteran access to care. An example of a third question that the researchers and the Delphi panelists came up with is how are each of the various dimensions of access related to functional outcomes and value for veterans? So again, these were the top 10 questions. And if you recall, part of the Delphi method was for us to winnow down even further. And we were able to come up with domains of which all of those questions fit right into. So what you see before you on the left-hand side are the access research domains. And then on the right-hand side, you have the lead research questions that are respective to each domain. So Karen and I were able to derive particular buckets, if you will, or research domains that made sense and allow for a category specific to the entire questions that were presented from the Delphi panel. So when you think about the 5 research domains, they were measurement of access, barriers to access, equity and subpopulation, effective interventions to improve access, and consequences of poor or better access to care. And as you see on the right are the related questions for each of the domains. Now what Karen and I now would ask for you all to do, which we've presented here, is ask you a poll question. As we think through what the panelists that were part of the Delphi process came up with in terms of the highest priority questions that the VA would need to consider, now that we have such a great audience in all of you, we wanted to ask you a similar question. That being, of the 5 access-related research questions identified by our Delphi panelists, which do you think is most important for the VA to prioritize first? And we actually have all 5 of those questions before you. So we understand that we may take you a few minutes to read through all of them. And so we've allotted time for you to be able to read through and then make the best choice.
Thanks, Demetria. That poll is up and running and people are making their choices. I'll go ahead and do my best to read the answer options. How should actual and perceived access be defined and measured so it is understandable, uses the best possible data, surveys, electronic, etc., and has meaningful implications for veteran outcomes both in VA and the community? Option 2, or B, how does structural, logistic, personal, and organizational barriers to access vary across subpopulations and interfere with veterans getting the care they need and or desire? Option C, how can we ensure equitable and effective access to services for veterans who are underrepresented or experience disparities in the VA, e.g. racial, ethnic minorities, LGBTQ, women, and those living on tribal lands? Next, what are the most effective and scalable interventions that improve access considering different modalities, settings, and targets. How does this vary for subpopulations? And last, does A, increased and or B, better access lead to improved quality care coordination, patient satisfaction, clinical outcomes, care continuity, and cost? What are the systemic consequences? And I think that probably gave people enough time to make their choices. So I'll go ahead and close the poll, share the results, and read them to you. 15% chose option A, 21% chose option B, 10% chose option C, 38%, the largest number, chose option D, and 10% chose option E. And with that, I'll go ahead and close the results and just turn things back over to you, Demetria, or Karen.
Thanks, Rob. Yeah, I think I'm going to take us through the next part of this now. And I want to thank everybody on the in this call or meeting, because that is really helpful to hear which one of these questions you think is most important and instructive for us too. Data are everywhere, so it's nice to understand that you are particularly interested in the interventions. Now, we were, as we have alluded to already, interested not only in understanding the perspectives of the people who became our Delphi panelists, the non-VA and VA access-related researchers and VA operational partners. We also wanted to engage the perspectives of veterans on this. In fact, that was a very important part of this process. And so the next few minutes is I'm going to devote to describing our process of engaging veterans and the insights that came from that process, because this is very much a two-part exploration, first the Delphi panel and then these veteran engagement sessions, and they dialogue very well with each other. So after we had completed the Delphi panel work, and that was in late September of 2020, we wanted to take it to veterans and have a series of dialogues and get feedback and input. So we ended up having 4 meetings across 3 veteran engagement panels. We were fortunate to be invited to speak and dialogue and present to Iowa City, the Iowa City VA veteran engagement panel in October. We made 2 appearances, 2 consecutive appearances at the Ann Arbor Veteran Research Engagement Council in November and December. And then also in November, we dialogued with and presented to the Center for the Veteran Engagement and Research Group at Bedford, Boston. And you can see on the slides that each of these panels or councils were supported by and housed within different centers at these locations. We were grateful to have the opportunity to be able to present to and get feedback from these groups. And even though each of these groups, differs in meaningful ways, all of them are linked by this mission to provide veteran perspectives and input on research studies. And the members in each of these groups also, they ranged quite a bit in terms of age, service era, branch, race, education, and gender. And at each of these, there were approximately 7 to 12 veterans in sessions. So we were grateful to do this opportunity to engage in this opportunity to dialogue with these folks. And we really drew a lot of inspiration in terms of our approach from a great toolkit that we want to give a shout out to here, Strengthening Excellence in Research Through Veteran Engagement, or the SERVE toolkit. You can see the URL here for that if you'd like to check that out. And as this document points out, this toolkit points out, there are a number of levels of engagement, possible engagement for veterans. Or with veterans, rather. And we really followed this consult model, this column that you can see here that is almost right in the middle of this slide. So we sought veterans' feedback and input on specific research activities. We wanted to understand or to ask them to help us understand the results of the Delphi panel and what was most meaningful to them about access research. And so this is what we really kind of emphasized in our work with them. But you can see again that this toolkit offers a variety of levels of engagement, and it's well worth checking out. So I want to describe for you a little bit here, not only our approach, but also what we sort of learned in this process before we sort of learned, let's say, methodologically, before I describe what we learned substantively. So, I mentioned that we made 4 appearances across 3 veteran engagement groups, and really learned a lot between meeting 1 and meeting 4. Each of these bolded points on this slide, walk you through or describe what our process was in terms of the basic structure of the presentation. And in italics, in the sub-bullet there, it sort of describes or captures what we learned and how we improved the opportunity to dialogue there. So of course we started off with introductions and background, our own personal backgrounds. And we realized later that it was really important to establish our own personal relationships to service. Demetria is the wife of a former veteran, and I am the daughter of a retired veteran. And Demetria's husband is of a different era. My father was is retired from Vietnam. And so being able to expose and describe our own personal connections to veterans and to military service more broadly was very helpful, because it established that we knew a little bit about what we were talking about, had lived a little bit of it, and particularly could engage with the discussion around the different implications of different service eras, which I'll describe for you in just a little bit. But because our connections to military service were across different generations, that was very helpful and meaningful. Of course, then we explained in describing what we were doing and setting up the discussion, we explained what BARC's mission was and the goals for the session. And we found, perhaps not surprisingly, it was really important to explain the context here, right, and to really emphasize and situate our work in terms of alignment with HSR&D's larger goals and, of course, their intention and the VA's intention to provide optimal care to veterans. We described, as part of our presentation, of course, the Delphi process and results, because that's what we wanted to get feedback on. But over the course of those 4 meetings, we learned quite a bit in terms of how helpful it was, or more helpful it was, to focus on the final results rather than getting too mired in the methodological weeds. We, I think, experienced the first dialogue as unwittingly, we presented to them unwittingly, or not really thinking fully about it, in a much more methodologically complex and unnecessarily so way to explain what we had done, and we really got lost in the academic speak of it. And that was unfortunate, because I think we did the project a disservice but we learned from that, and then the 2nd and 3rd and 4th meetings, we tried to focus on what was much more important, in this case, the final results rather than the methodological process. And then, of course, we invited reactions and feedback. And in this, too, we learned quite a bit. We found that it was more fruitful to avoid these sort of blanket questions, what are your reactions to this list? That wasn't very productive. And instead, what we tried to do was to translate that academic abstraction, really, to engage more meaningful veteran experiences. And we also learned over the course of these 4 meetings that it was particularly dialogic and fruitful to focus on barriers and equity and interventions, because those were the things that the dialogues themselves gravitated towards, because those were, particularly with barriers and equity, those were particularly germane to veteran experiences. So we had a lot of great conversations about that. And so I want to show you in these next few slides here, examples of how we approached this. So for instance, for the barriers to access, what we would do is present or remind folks about what the question related to this was that had come from the Delphi panel work. But then, and then you can see in this slide, this is what is in italics. But then in the non-italicized questions, those were the questions that we really used as the jumping off point for the discussion. So, with regard to barriers, what are some of the things that you think act as barriers to access to care through the VA? Why or how are they barriers? And again, these kind of questions generated a lot of fruitful dialogue, and I'll get to that substance in here in just a second. But translating the, as I said before, the academic abstraction, in some ways, the researchers speak, to ground it in meaningful experiences that the veterans have had and their perspective that they have accumulated over the course of their careers in the military was very helpful. And they were so generous and thoughtful with the way that they approached the discussion. So similarly, this question about equity across veterans. Do you think that there are differences in access to care across the veteran population? What are those differences and why do you think they exist? What differences should be addressed immediately? You can, again, as with the former slide, it is these kind of questions generated some very thoughtful discussion. And then similarly, with the other question that we particularly focused on in these discussions, we translated the researchers speak around interventions to, what ideas do you have for how access issues within the VA might be addressed? So with these kind of discussions, we got a lot of very thoughtful feedback. And these next two slides capture what we really took away ultimately from these discussions. There were a number of significant needs for access to care that these veterans identified. And you can see them listed here on the slide. One of the most relevant was the dissemination, this issue of dissemination of VA services. People talked a fair amount about the sometimes inconsistent, or at least the perception of inconsistent dissemination of services and resources across the VA system. And related to this, the fact that in some cases the perception was that the details of the services were not very accessible and not very clear. And that leads to this second main bullet point here, which is really, really important, the understanding and perception of veterans that services, there was not a lot of or adequate communication about services that at least reached them. So there's a lot of talk about how there was a need for more widespread marketing about what services the VA had to offer and how one could or should access various services. And there was a lot of talk about the need for increased individualized contact, person-to-person outreach to engage in this kind of communication. One of the quotes that Demetria and I both really liked was, because we think it's really telling around this is like showing where the doors to services are. If you don't show people where the door is, there's no access. So it's pretty poignant, and really over the course of these 4 meetings, this point was mentioned and brought up quite a bit. People also talked about the issue of this connection and sometimes lack of connection or relationship to local communities and healthcare facilities. So veterans talked about the need for having more direct and open and clearly accessible partnerships with community organizations, in the areas that veterans lived, in order to work together and to, mutually and collectively serve veterans care. And similarly, they talked about the need or desire to have more relationships, VA relationships with community-based healthcare clinics and hospitals. They also talked a lot about the issue of telehealth support. So you may recall that there were a number of interventions that the VA has focused on in terms of in the digital domain, and certainly I think the VA is a leader in this field. But one of the issues that the veterans brought up is that not everybody understands or has equitable knowledge about or access to some of these digital interventions, the telehealth support. And so they talked about the need for education about technological resources and different options for telehealth care. And this is particularly germane to the issue of generational differences across veterans, because many of the older veterans expressed that they were less technologically savvy, and I mean, certainly that's not always the case, but it trended more that way, that the younger veterans were a little bit more familiar with how some of these things worked, and therefore the relationships to technology differed quite a bit. So these are some of the significant needs for access that came from these discussions. But there were also a couple of others, too, that stood out thematically from these discussions. And we mention them here because we think they're important, and they're also, to some degree, related to access. So, certainly not everyone felt this way, but people did talk about how there was a thread in some of the veteran culture, veteran experience that had to do with distrust of VA system or healthcare professionals. And to the extent that people felt this way, that also impacted the interactions they would have with the system or with providers, and made their experience of care less optimal. There was also this theme about how important knowledge of military culture is, and how important it is for providers and the system in general, but particularly those individual providers that people have contact with, to recognize that there is this diversity of need, healthcare and orientation by veterans. And again, we see here the relevance of this across different generations. So, the Vietnam era veterans might have a different experience and different set of needs than those from Iraqi freedom or any other more recent conflict. And there was also this recognition that, or this desire to have more overt recognition of the healthcare needs having to do with the alignment of the time since veterans' disconnection from service. In other words, there were different needs identified around, active duty versus reservists, and also, in terms of, again, the time in which, if it's been, 5 years since service disconnection versus, versus 30 or 40, that had a lot to do with people's ability and understanding about how to interact with the system. And of course, it's hard to speak in blanket generalities here, but these are because everybody's experience is different, and lots of people were contributing to this discussion. But these were important themes that emerged from these discussions. And so Demetria and I found it very thought-provoking and very meaningful to hear veterans react to the work of the Delphi panel, and then to show how and why some of those issues are meaningful to them. And Demetria, I'll let you describe what our next steps are here.
So after Karen and I were able to conduct the Modified Delphi panel, as well as have discussions with the Veteran Engagement Board, we wanted to make sure that we were able to offer you insight into what's next, right? What do we do with what we've learned? And as part of our funded project through HSR&D, there are a couple of things that we're going to do in terms of moving this forward. The first thing we're going to do is complete a 5-year research roadmap. And so this will give us an idea around exactly what are some key areas we should be focusing on as a VA system that's highest priority across the next sort of 5 years, given the findings that we have from various projects that are being done within this research agenda. The second thing that we're going to do is have a culmination of all the final results, and that will be presented to HSR&D, operational partners, and other key stakeholders. Because we don't want to just have results from the research. We don't want to just disseminate the findings, but we actually want there to be some action behind the significant results that we found, which leads us to 3, which is being able to inform the funding priorities across this year and in years to come. And so that's where we see the next steps of this process going. And so with that, Karen and I would like to extend our sincere thank you for not only attending our CyberSeminar this morning, but also being participatory in the polling question. And at this time, we would really like to turn it over to you, the audience, and we will humbly accept any questions that you may have, and we encourage you to post them now, and we are available to be able to answer any questions or to engage with you in regards to any of the research and any of the findings that we have to date.
Thanks, Demetria. We do have a number of questions queued up, but just as a reminder, attendees, please send your questions to the Q&A panel, not the chat panel. We do have a few in the chat panel, and I'll try to read those, but I will prioritize questions that can't come into the Q&A panel. And the first one came up fairly early. This person asks, what is the lens being used for, in quotes, most important for VA to prioritize, i.e. for saving money, for highest return on investment, for highest veteran satisfaction, or highest veteran health outcomes?
Demetria, I can maybe take a stab at that.
Go ahead. Yeah, that's a really interesting question and a really good question. But go ahead, Karen, and I also have some thoughts, but go ahead.
Okay. Yeah, so I appreciate that question. With the modified Delphi approach, the way we engage this is that, we ourselves have done, quite a lot of work in reading and engagement with a variety of access lenses. As I mentioned before, a lot of the work of the VARC has been drawing on work like the Fortney model. But what we wanted to do was engage researchers and operational partners to understand where they were coming from. So we didn't want to put a lens on at the outset what they, what kind of universe of possibilities there was, which is why we engaged in the first round of questioning, or the first round of the Delphi panel work by putting it to them. So we kept it very open, and we also, again, solicited perspectives not only from VA researchers but also non-VA researchers, who both of which groups had experience in access research, but also VA operational partners. So we wanted a diversity of lenses. We wanted a diversity of perspectives. And as Demetria mentioned, we ultimately wound up with 83 from that open call, essentially, to once people agreed to be a panelist and to participate in the process. We issued what started off as an open call. We wanted to know in their own words, from their perspective, what were the most 1 to 3 important questions for in the access field for VA to try to move forward. And that resulted actually in about 150-ish questions that were then, once redundancies and duplicates and so on were eliminated, it resulted in 83 unique questions. So then we took those from there and and winnowed in the way that Demetria described. But the whole point of my answer here is essentially we were trying not to put a particular lens on other than to select panelists who could come at it from a diversity of perspectives and then, move toward consensus in the group from there.
Mm-hmm.
Thank you. Simply, what measures of the access do you recommend?
What measures of access? Well, I would turn the informed answer to that over to one of the other VARC work groups that has been focused on metric compilation and so on. I think it's really difficult to answer that question in a broad sense because different metrics are going to be more applicable and relevant to different dimensions of access. But one of the past CyberSeminars, I want to say it was in October, perhaps it was in November, was devoted, though, precisely to this issue of metrics. And so it's a great resource. I encourage you to look back at that. They talk a lot. Peter Caboli, who leads that work group, gave a great presentation about a variety of different metrics that are useful. But it really depends on what dimension of access you're talking about, and your samples and what kind of data are available, I think.
And I also think that it's important, although it's not going to give you a concrete answer, but to also to consider, to Karen's point, not just sort of the dimension of access, but also the audience, because one of the things that we learned, we weren't able to tease out during this session is, as you all know, if you work in access research, is that it really depends on who you ask how it's defined. And so one of the things that we learned, particularly when we're speaking with the veterans, is how they viewed access and what it really meant to them and how it should be measured. So I think, to Karen's point, obviously that should go out to folks that really do kind of focus on this each and every day. But I also think that it's important to consider the end users of the access, if you will, that you're considering in order to have equal measure of the folks that are delivering the care, as well as folks that are on the receiving end, in terms of what it really means and what you should measure in terms of what matters to each respective group.
Thank you. This one is 3 different questions. You may be able to address them all together. Thank you for this great info. Why weren't veterans included in the Delphi panels? Why is there so much work done before consulting the target stakeholders? When will the expertise based on experience be regarded as highly as book knowledge expertise?
Well, let me, that's a great series of questions. Let me take the last one first. And it was certainly our intention the whole way to not to prioritize one group over another. We wanted to be, and in fact, as I tried to emphasize in the discussion about the veteran engagement panel sessions, just how much we value veteran perspectives here. I think what we wanted to do more than anything was to, because HSR&D is looking to fund research per se, or research specifically, we wanted to have engaged conversations with people who actively did research, access-related researchers, and again, as we said, both within the VA and outside the VA, so that we could understand what the research universe was and what the consensus was, or come to consensus among researchers specifically about which direction to go, where the gaps were and what was most important from a research-related perspective to move. And we engaged operational partners, of course, because they're critical in terms of understanding where the gaps are from their perspective too. But the focus on engaging veterans in that second part of that was specifically to prioritize them. We didn't want those voices to be lost in the crowd. We wanted to be able to understand, as we described, what the meaning of access research or access issues were to veterans and are or is to veterans. And we didn't want that to get lost. So it certainly was not our intention to present this like the veteran experience was secondary. It was absolutely not. In fact, there are a number of insights, some of which we talked about here, number of insights that Demetria and I and VARC would like to move forward with, if at all possible, because they were so, one, profound, and two, heard very clearly by us in the process of this veteran engagement. So, for us, it was very much an equal two-part, and if one had to be valued over the other, certainly the veteran experience was very critical.
Don't the access-related questions that we prioritize in the poll have to be pursued in a certain order? For example, you have to define access before asking which interventions increase it.
Right. That is a very good point. And in fact, in our recommendations to HSR&D, as Demetria described our next steps, we're going to be engaging, we're going to be reporting these results and insights and questions to HSR&D, and with the recommendation that there is in fact an order that at least to some degree that makes sense. There's some overlap here. It's not necessarily all, one leads to two and two leads to three and three leads to four. So there's some overlap. But in fact, on the panel, the Delphi panel, this was one of the points that emerged too, that in fact, there is an order, circular to some degree, a circular order to these questions, and it makes logical sense to at least have some engagement in that temporal order. I would submit that again, it's not absolute that one has to be answered over another, but it does make a logical sense, and there's certainly a strong argument for that.
Karen and Demetria, we are fast approaching the top of the hour. I think we discussed it, but I don't remember what your answer was. Is it okay if we go over by a few minutes to answer some more questions?
Sure, that's fine with me.
Yes, I'm available.
Okay. Attendees, if you need to leave right away, please do stick around for the short survey that comes up when you leave the webinar. This person writes, after the final session and synthesizing the results, were you able to communicate your findings to the veterans involved in the study?
I guess I'm trying to interpret the question. We have not yet engaged in the final, in the sort of final synthesis of what we just presented to you, but that is part of, as Demetria described, that's part of the communication to stakeholders. That's in our next, one of our next steps. So and stakeholder very much includes veterans. So our plan is to circle back with the veteran engagement groups and talk about the best way to disseminate those findings and the themes that emerged. We'd love to be able to come back and have another dialogue. If that fails, since there's certainly a number of people who are would like to have time in these agendas for these veteran engagement panels. If that fails, we can present the work in a written form and send it. But so we haven't been able to yet. The last, as I mentioned, the last of these dialogues with veterans was in mid-December, and of course we're just in early January now. So we haven't had a chance to do that, but that is certainly on the plan.
And one thing to note too is that we also did circle back with the veteran board liaison to ensure that they had the link to extend the opportunity for the veterans and those that are involved with the veteran engagement boards to participate in this CyberSeminar if they chose, because moving forward, to Karen's point, we wanted, if they were available to attend the CyberSeminar, we wanted them to join it to sort of hear how we coalesced all of the findings to this point, and then we will be moving forward with communicating to them the final presentations as well.
Thank you. I'm going to add these two questions together. About how many veterans participated in the Delphi process, and how did the findings from the Delphi and the veterans group agree/disagree with each other?
So no veterans participated in the Delphi panel. The Delphi panel was only the VA and non-VA researchers and then the VA operational partners. Mm-hmm. But if you mean the number of veterans in the veteran engagement feedback sessions, there were approximately, let me think, so there were approximately 20 across the 20 or 25 across the three groups that we engaged with. And they varied quite a bit in terms of their, service era, branch, race, education, gender. There's really quite a variety, and the diversity of perspectives there was and experiences was really valuable. And Rob, what was the second part of the question?
The second part was, how did the Delphi and the veterans group agree or disagree with each other?
So the synthesis of the two perspectives is really an important point here. The two parts of this endeavor, the Delphi panel itself and the engagement with veterans for the feedback about it, were meant to dialogue, but they still were sort of occupying a little bit different domains. We wanted to know from a research perspective, and this is the goal of the Delphi panel, we wanted to know from a research perspective what were the gaps in the research field about access, right? And therefore, and specifically, obviously, with VA, but also within that broader context. So what were the areas that HSR&D might consider funding to fill some of those gaps, to understand certain things better? And so the Delphi panel process was just about identifying the leading research questions of the group, or that the group came to consensus on, that reflected the field more broadly. And then the part about the veterans was, since certainly some veterans are researchers, but not all are veterans, of course, or most veterans are researchers themselves. What we wanted to know from the veterans was what their experience was with access-related barriers or other issues that they had seen. And that's why we engaged them in, we took, as Demetria explained, we took question by question that of those 5 leading questions that the Delphi panelists had identified, and asked veterans for their response to it. And those responses, from those responses came the themes that we described a few minutes ago in terms of what was most relevant to them. And so just to take one example, there's a lot to cover there, but just to take one example, the communication piece that, perceived missing communication piece from the veteran perspective was something that could fit in to an intervention, let's say, or some other possible funding mechanism that came through, that came from one of those panelists' identified research domains. But it doesn't map on exactly. But it was enormously helpful because that gives us an idea about where the gaps are, and then, gives us some insight about what type of intervention might be helpful from a veteran perspective. So they dialogue nicely, but they don't map on exactly. I think that the veteran perspective helps us grow and understand better what might work, within the research kind of angle.
Thank you. How do we take some of the research noted for access and translate it into outreach initiatives? Is this something that can potentially drive outreach?
I would love to, Rob, is it possible to dialogue with the person who asked the question? Because I think I'd like a little bit more clarification about what outreach in this case means. But is it possible to do that or no?
The person can certainly write back in, but honestly, given the amount of time, I think we should just move on, and that person should email one or both of you.
Okay, that's great.
Okay.
Sure, that's great. Yeah. And actually, and that's a great point, Rob. Demetria and I really do, we welcome very much any kind of email communication or other kind of communication that folks who are still on this call would like to engage in. Happy to answer any more questions, either about methodological matters or substantive matters, or about BARC in general or the Stakeholder Engagement Group. So you can always reach us by email.
Okay, I think I can glean one or two more questions out of the chat.
Okay.
I see the Office of Access to Care and Telehealth needing to be looped into this excellent research. Will you be sharing and reaching out?
Yes, absolutely.
Yes.
Yeah. No, you go ahead, Demetria, please.
I was going to say, so you mentioned Office of Telehealth and Office of, what was the other office, Rob?
Give me a second and I'll get back to it.
While you're finding it, what I will say is at the outset of the project, one of the things I think that is important is that there have been key meetings across senior leadership, and it was expansive. As you're mentioning telehealth, what comes to mind is that we've had conversations with rural health, for example, as well. So I think your point is well taken, and I do think that it's something that we have moved forward with. Is we want it to be inclusive and make sure that we sort of reach out to all of the respective offices that can not only be a part of the conversation, but will be key in terms of being able to move forward and implement some of these results, as well as potentially some of these prospective interventions in the future. So there is a partnership across a variety of offices that will absolutely not only have access to this research, but are included in the process.
Yeah, and I'll add too that there were a number of offices that operational partners that were engaged in this already. And I know in that slide where we showed essentially the word cloud of the participants, it was hard probably to identify who those were. But we engaged the operational partners who were part of the Delphi work, included folks from the Veterans Access to Care, OVAC, the Office of Mental Health and Suicide Prevention, Office of Primary Care Operations, Office of Community Care, Office of Connected Care, Office of Specialty Care Services, Office of Rural Health, Office of Health Equity, and Office of Mental Health. So those are some great operational partners, but certainly others, as Demetria just said, others will be looped in as well. We want to, involve as many folks as we can in terms of trying to identify opportunities to move this forward.
The questioner used the terms Office of Access to Care and Telehealth, so I think you addressed everything that was included in the question. And that really was the final question that I could get out of the chat. So let me give you both an opportunity to make closing comments, and then I'll just go ahead and close right after that. So in no particular order, Demetria, because I see your name first in the slide, because I'm looking from top to bottom. I'm sorry, bottom to top.
No problem, Rob. Again, I just wanted to take the opportunity to thank all of you for attending. I know time is precious, and I in particular appreciate you spending it with us. I also appreciate all of the degree of engagement that you all have extended over the course of our time together this morning. It's been really not only a good opportunity to share our work, but it's been a good opportunity to learn from you all, as well as to be able to respond to a lot of the questions that are out there. One of the things that I will take away is that we are on the right track. And I say that because of the kinds of questions that we've gotten lead me to believe that you all are, this is top of mind for you all as well. And it's something that I think has legs, and we will be able to push forward, and that we have the support both inside and outside of the VA. And so I thank you for that.
Karen?
Yeah, and so I second everything that Demetria said. I also want to give a special thank you and acknowledgement again to the consortium, the Veteran Access Research Consortium, which is a great group of people who really care about moving this forward, and also a very special thanks to the ARC network more broadly, which is a larger group of access-related researchers and access-interested, let's say, researchers and people who care about improving the access to care for veterans. And relatedly to HSR&D, who has funded this whole enterprise and is interested and invested in trying to fund research that has been identified here by the panelists and veterans as being very important. And finally, and certainly extremely importantly, we want to thank everybody who participated in this process, including you all who have tuned in to hear more about our methodology and our ultimate findings and our future directions, but particularly the people who participated in the Delphi panel and the veterans who engaged with us about these issues. Our work completely rests on the shoulders of people who have this expertise, whether it's in access research or in lived experience, as in the case of the veterans. So thanks to everyone, and this was a wonderful experience, and we hope to hear from you. Those of you who are working in this field, those of you who have other thoughts, please don't hesitate to reach out to us and continue to help us engage this, because we think it's an important issue and will only continue to get more important, I think, over the coming years.